Welcome, everyone. This is the COVID and harm reduction panel, so I'm not going to try and disguise my burnout. I'm going to rely heavily on the welcome notes I've prepared. So please bear with me and we will get started soon. Really excited for this session and really grateful for everyone who's taking the time to participate. Good afternoon and welcome to the day one closing plenary of the 2021 Southern SSP Institute. My name is Lily Armstrong and I serve as a senior manager on NASTAD's Drug User Health Program, but I'm a resident of North Carolina and I'm proud to be steeped in Southern harm reduction all year round. My co-moderator Kirsten Forseth and I are glad to be welcoming some excellent panelists to discuss this afternoon's topic, harm reduction in the COVID-19 era. We'll be discussing how different programs that engage with people who use drugs have responded over the last year and what needs and opportunities for further program growth and tailoring have been revealed, specifically in the areas of health for incarcerated people, low barrier medical care for people who use drugs, and housing access. After some introductions, we'll hear from each of our panelists and then get into some discussion and audience questions. My colleagues are following the chat for questions and tech issues, so please feel free to chime in there. If you haven't heard already, all of our sessions today are being recorded, and I'm sure we can make slides available after the presentations. So I am very pleased to welcome our speakers today. Lauren Brinkley Rubenstein, PhD, is an assistant professor of social medicine at UNC Chapel Hill, as well as a core faculty member in the UNC Center for Health Equity Research. She received her PhD in Community Research and Action at Vanderbilt University and completed a postdoctoral fellowship at the Brown University Warren Alpert Medical School, where she worked directly on Rhode Island's implementation of system-wide MAT access for incarcerated people. Dr. Brinkley Rubenstein's research focuses on how incarceration can impact health outcomes, including experiences of HIV, substance use disorder, and drug overdose. Since 2020, she is a co-founder and co-lead investigator of the COVID Prison Project, a national effort to document the impact of COVID-19 on correctional system residents and staff. Welcome, Lauren. Thank you for being here today. Jesse Mesenberg and Katie Evans have both been working at the Spark Center for the last 2 of the 3 years that it has been in operation in Baltimore, Maryland. Jesse is a certified registered nurse practitioner who works dually with Baltimore City's Health Department, STI Clinic, and Spark, which is a sex worker health program. And I will ask one of you to give us the full acronym when you start speaking. And Katie Evans is a licensed social worker. Jesse was brought onto Spark's team to support a research study, Pearl, in prescribing PrEP to sex workers, and her role has grown dramatically both at Spark and with Baltimore City Health Department through a variety of initiatives. She has done everything from responding to a hepatitis A outbreak at the beginning of the pandemic to helping to develop COVID safety policies for Spark and supporting the Baltimore City Health Department in its vaccine rollout plans for vulnerable populations. Katie started with Spark as the outreach coordinator and similarly has seen a shift in roles and responsibilities over the past year as she has worked to oversee all center operations and staffing during the pandemic, as well as being the primary direct service provider during the first few months that Spark was closed due to COVID. Katie and Jesse can most frequently be found trying to plan the next level of programming and providing street medicine and counseling. Welcome to you both. And Lawson Keppel received his Master's of Social Work with a focus on substance use, policy, and mental health in 2019. He co-founded Virginia Harm Reduction Coalition in 2018 to prevent overdose deaths and empower people who use drugs. It has been NASTAD's pleasure to work with Lawson, Ariel, and the rest of their team over the past year on a CDC demonstration project on implementing patient navigation services into SSP settings, and to hear about all of the great work that they're doing in Virginia. So welcome, Lawson. And thank you, as always, to our lovely audience for joining us this afternoon. With that, we will get started. Is there anyone who would like to speak first? I'm going to start picking names.
Happy to start. If that, I think I got the question.
Yes, please go ahead. Do you all have slides that you want to throw to?
We do. I think it's gonna let me. All right.
Beautiful.
All right. Let me move this out of the way so we can see our own
You can make them a
information.
little.
Oh yeah.
Oh yeah.
All right. Now we're back and rolling. Can everybody see my screen? All right. So thank you for the introduction, Lily. I'm Katie.
I'm Jessie.
This is our Spark Center, pictured above or pictured in front of you. Spark stands for Sex Workers Promoting Action, Risk Reduction, and Community Mobilization. Though I will say our target population has shifted during COVID from cis women, trans women, and non-binary folks who are sex workers to everybody who uses drugs. So we'll explain some of our service provision shifting in the coming slides, but just a little context.
And we're located in Baltimore, Maryland.
Oh yeah.
Hi everyone, I'm Jessie. I want to start by just, I think it might be helpful to talk about what we did pre-COVID, and then we'll talk about what we did after COVID, which will kind of show you how we've evolved over the past year. So pre-COVID, we our brick and mortar center that's open Monday through Friday, and we partner with a number of different organizations, or we partnered with a number of different organizations that all provided different care on different days. So on Mondays, we did buprenorphine with an organization called BHLI. On another day of the week, we did birth control. 2 days a week, I was here doing HIV, STI, Hep C testing, and treatments and referrals, and also PrEP. We had legal services, I think a couple days a month. We offered individual therapy and case management ongoing Monday through Friday in-house. And then we also did syringe services, but we partnered with Baltimore Harm Reduction Coalition to provide those services. So this is all pre-COVID, before March of 2020. And we did overdose prevention training and naloxone distribution. Most of our services were centered around our brick and mortar. So we provided showers, laundry, secure lockers for people, computers, and computer access, and a food pantry, along with like yoga once a week and a twerk shop once a week and an art class. So that was what our center kind of looked like before a year ago.
And so prior to COVID, I was the coordinator for all of our outreach services, and they were all nighttime focused. So most of our shifts occurred between 8 p.m. and 2 a.m. A lot of them 10 p.m. to 2 a.m. on the weekends, or during the weekday, it would be more like 9 to 1, 8 to 12. And we had specific areas that we went to based on instances of sex work and drug use, and those were all informed by research done by our PI, Susan Sherman. So Spark was born out of research studies at Johns Hopkins School of Public Health. Spark is now like this, the study has now ended and we're just continuing to operate. But that's how we sort of knew where to be and where to find people and how to best connect with people. We'd see between 15 and 30 people a night. And our primary goal was always to offer services on the spot. So whatever supplies people needed, whatever micro-counseling referrals. And then the secondary piece was also to let them know that Spark, the brick and mortar, had a buffet of services available to them should they choose to engage in that. But that was always like the second piece of information was come see us during the day, but first, how can we meet you here tonight? March happened. Everything shut down for about 2 weeks. And then by the beginning of April, we were back up and running with a very different model of outreach. We have this lovely van. She's one of my favorite employees, and she is the vehicle by which we deliver everything. So we have safer sex supplies, safer drug use supplies. In October of 2020, we became our own syringe service program. And prior to that, we were still operating as a collaborative partner of Baltimore Harm Reduction Coalition. And the organizations in Baltimore did a phenomenal job working together to make sure everybody continued to have access to supplies throughout the pandemic. A lot of government-based services closed down and stayed closed longer than the community-based organizations. So we were all working together to make sure like each center had what they needed, and we were sharing information, and our collaboration among other harm reduction providers grew a lot during this time. We also added additional services. So we started doing clothing deliveries and food box deliveries. Just anything that people requested, we tried to meet those needs.
Yeah, and clinical wise, so I feel like a big part of our shift is before COVID, we had a buffet of services at our brick and mortar, but they were all sort of siloed and disjointed in some ways because of that, because they were all sort of through different partner organizations. Since COVID, we've kind of grown to provide these services more on our own. So I've expanded also our center is still closed, like the brick and mortar center is still closed. So clinical care has expanded to be more street-based medicine, where I provide HIV testing, Hep C testing, and STI testing, treatment and referrals, vaccinations. There was a Hep A outbreak earlier, from last March to about the fall. So we provided intensive Hep A response on that front. We also got flu vaccines. My care has really expanded to doing wound care. So that's what people need on the street. And I did used to see some wounds, but the care that the needs and the care that I'm providing on the street is definitely slightly different. A lot less prep, a lot more like wound care and like almost like emergency medicine, and triaging right there. I also started providing birth control, various kinds of pills and depot that I have with me that I can provide right there on the spot. And then, I'm a family nurse practitioner, so I can just triage other medical needs and provide referrals as well.
Yeah. And while Jessie has her test cooking, either somebody on our outreach team or myself will be there talking to the person and seeing what their other sort of social health type needs may be, to support the holistic nature of people's healthcare needs. We've grown a lot, to put it lightly. In June, we also added a fixed site outreach model. So we have a community partner right around the corner within walking distance of Spark that provides lunches every day called Paul's Place. So we set up outside of Paul's Place. Jessie does testing there. She does all of the same healthcare services that she described, and all of the supplies that we have available. People can access them there. And so it's a great option for people to get follow-up care whenever they don't have other ways of contacting us. They can just keep coming back to the same site every Wednesday and we'll be there. Go ahead.
We also, jumping off of that though, is we have a phone number that people can text to get these deliveries. So people can text and say, hey, I need shorts, I need new ones, I need shorts, I need shoes, I'm a size 6 or whatever, and we'll drop it off to them. And that helps provide follow-up too, because people will say, oh, I need wound care, I'm having discharge or whatever. So we'll kind of have home health visits, appointment-based with healthcare. So and then we also just like walk around the street and do sort of rogue street medicine.
Yeah. One of the great things that we've seen with having this Google Voice number and having the weekly deliveries is that we just have better relationships with people in outreach than we ever had before. Previously, our outreach team was staffed by like really, really, truly wonderful casual staff members. But the downside of that model is that the shift is different people every time. Now that it's staffed by our full-time team, people see the same staff every week. So you get to know people a little bit better. We get to know people a little bit better. With like wounds like Jessie's talking about, I could see somebody one week, and I'm a different kind of healthcare professional. I'm not trained in wound care in any way similar to Jessie is, but I can see somebody one week and see what their wounds looks like, and then see them the next week and have an idea if it's better, worse, more inflamed, less inflamed. And we know that going to the hospital and healthcare services are just not designed for people who use drugs. So it really takes so much follow-up to get somebody to the hospital or to get somebody into a more regular wound care outpatient setting, that having that regular follow-up has been a real game changer for us. To demonstrate how much we've grown, this red line was our encounter. So these aren't all unique individuals, just the number of people that we would encounter each month. So the red line is 2019. This orange line is 2020. So you can see March is where the pandemic hit, and then it grew by 100 people, and then it grew by 100 people, and then 200 people, and then 300 people. It's been a whirlwind, to say the least, but a lot of it is because we've been able to have this consistency with our service provision, and so people can refer their neighbors, and we have blocks where like we start with one house, and then by the next month we have 5 houses on that block because people will talk to each other and share information. So we haven't really done much advertisement or anything like that. It's all been word of mouth that's kept us moving in this growing direction. And here's our contact information. You're also welcome to follow us on Instagram. There's our lovely faces, and thank you for having us.
Yeah.
Thank you so much for that, to both of you, for joining us. Lawson or Lauren, any preference on who goes next?
Happy to go.
Thanks. Welcome.
Thank you. Okay. Just sharing my screen here. Okay, great. So thanks for having me today. I'm going to chat a little bit about COVID-19 in the context of carceral settings, and then speak on the relationship between incarceration, COVID-19, and also harm reduction in the context of substance use, overdose risk, and also incarceration itself. So many of you may be very aware of this, but just to set the stage, people who are incarcerated are at extreme risk of COVID-19 for 2 reasons. And really the first reason is that people on average who are incarcerated tend to have a higher burden of chronic illness compared to the general population. So on average, people who are incarcerated have at least one chronic condition. We also have an aging prison population. In particular, about 11% of people who are incarcerated in our prison system are over the age of 55. And so this puts people at risk of suffering severely from COVID-19. And then the other really important thing to know is that the built environment, the architecture of prisons and jails are also put people at extreme risk of because they're in those settings. And so in this country, prisons are at about 104% of capacity, so overcrowded at baseline. In addition, many jails and prisons are congregate style living facilities, and so people cannot engage in what we used in the community as one of the most efficient prevention strategies, and that is social distancing. And even when there may be a single cell or a double cell type architecture in the building, people still eat together, they recreate together, they use shared bathrooms, et cetera. And so very hard to engage in social distancing in prisons and jails. And as probably no surprise to most of you, there are also other missing prevention strategies in the carceral setting. And so things like soap and hand sanitizer are usually not available. They become more available over time, but still not at the levels that we would want to see. We see some states have mask mandates for availability of masks, but those slowly came on board over time. And still some places don't. And we've also seen that in some places where there is a mask mandate and there might be availability of masks for staff, there's a large refusal rate with staff refusing to wear them. There are also some barriers to reporting symptoms. So if someone is incarcerated and might be not feeling well, they may be reluctant to report those symptoms to correctional officers or medical staff in those facilities. One of those reasons may be medical copay. So would folks mind muting? I'm just getting some feedback. Okay, great. Thank you so much. Medical copays are in place in most prison and jail systems, and that means if I make a sick call because I'm not feeling well, I may be charged a couple of dollars, which is a significant amount of money to an incarcerated person, so you may not want to pay that. In addition, it's also true that in a lot of settings, they don't have the capacity to engage in what we would think of as medical best practice for medical isolation or quarantine. And so those settings, those conditions often mirror solitary confinement, which we know is harmful to health. Our group has done some research that showed that any amount of time spent in solitary confinement is associated with a greater risk of death post-release. And so many people don't want to be put in those types of conditions if they have been exposed to COVID or have COVID. And then there's this giant issue of testing where there hasn't been nearly enough testing at the beginning or now, and there still remains no cogent best practice relevant to testing as a mitigation strategy. And most prison and jail systems don't have a long-term plan. So in response to this, we also, saw the writing on the wall in March of 2020. We started the COVID Prison Project. And the real aim of the COVID Prison Project is to illuminate what's happening behind the walls, to encourage accountability, data transparency from prison and jail systems across the country. And so we've been tracking data, aggregating it, publicly sharing it, and giving it to policymakers, to advocates who are trying to make change in their systems. We've been working on some federal legislation with some senators relevant to data transparency and also best practices in the Federal Bureau of Prisons. The numbers as of, I think today is the 2nd, I don't know, time is hard to keep track of. As of March 2nd, these are the numbers that the COVID Prison Project is reporting. And so nearly 400,000 cases among people in prisons in this country, almost 2,400 deaths of people who are incarcerated in prisons, around 94,000 cases among staff who work in prisons, and 155 deaths of people who work in prisons in America. We've been tracking this data over time, and so really this was for the National Academies of Science did a report on decarceration this summer, and this was some data that we, some analysis we did for them. If we were to look at these trends and look at them up until the current month, they would look very similar, except for we would see that gap between the general population, staff, and incarcerated people continue to widen over time. And just to orient you here, the light blue line at the bottom is the general population case rate for COVID. The lighter sort of middle, maybe UNC blue there in the middle is staff, and the top Duke blue line is incarcerated people. And there's an important story here, both in the disparity in the case rate between the general population, staff, and people who are incarcerated. But if we look all the way back to the beginning of the pandemic, we see that for staff rates were actually higher at the very beginning, and then the lines cross. And so this can tell us maybe two things. Both things could be true, or it could be one or the other. One is that we've long suspected that staff were the folks who brought it into prison facilities at the very beginning of the pandemic and caused much of the devastation that we have seen across the country. And then the other thing that's important here is that staff probably had more access to testing at the beginning of the pandemic than incarcerated folks did. And so this could be an artifact of increased access to testing and not a reflection of actual case rates. We've also been doing some hotspot analysis. This is an older map, but the story is always the same. Most of the prison systems across the country have been in hotspot status most of the months as we go on. And the way that we're looking at this is using the Kaiser Family Foundation definition of a hotspot, and it really has two main components. So thinking about case rate increases over a 2-week period, and also test positivity rates. And so this is from August to September, but if we looked at it today, it would look very similar. And really the driving point here is that most of the prisons in this country have gone in and out of outbreak status with little ability to mitigate COVID-19 outbreaks. And I did just want to touch really briefly on vaccines. A lot of our work that we're doing now is focused on vaccine allocation, prioritization, and then deployment. We've been looking at state plans for vaccine prioritization. They change all the time. So we looked at the initial plans in October that were interim. Then we looked at the final plans that were turned into the CDC in December. And since then, what the states said they were going to do has changed quite a bit over time. But this is really showing us the green are the states that in their plans have prioritized people who are incarcerated in phase 1. And when you see a stripe through one of those green states, it means that only some proportion of the incarcerated population is included, usually folks who are older, 75 plus, 65 plus. When we look at the map, we see the yellow states. Those are states that put incarcerated populations in phase 2, so not highest priority, not lowest priority. And then we see Missouri and Tennessee made the decision to basically not prioritize incarcerated populations at all and put them at the lowest level with sort of general population. And then a lot of states kept it vague. So the CDC pushed states to include critical populations, which included people who are incarcerated. So all of the plans have some nod, some acknowledgement of the incarcerated population and talk about how they're going to fit them into their plans broadly. But some states made the decision to not explicitly include incarcerated populations in any phase. And I did just want to touch on harm reduction a little bit in a broader sense. So, we've been talking about testing, about mask mandates, about vaccine deployment, but at the end of the day, the most effective way to mitigate COVID-19 in prisons and jails is to engage in large-scale decarceration. And so the work that we're doing has an abolition framework, and what COVID-19 has done is really shown a light on the fact that carceral spaces are not safe. They are not places of health. They are not run by folks who know how to manage a pandemic or a crisis like this. And so in the context of COVID-19, before COVID-19 and after COVID-19, we really should not have had as many people incarcerated in this country. And because of our punitive criminal legal system, we found ourselves in an absolute crisis. So we need to move forward with a theory of abolition and decarceration as the #1 way to avoid a public health crisis, the kind of devastation that we've seen over the past year for people who are incarcerated. It's also important, there's a lot of tension in this work. We're always thinking about decarceration, about abolition. Then we're also thinking about conditions of confinement, how to make those conditions more healthy for people who are caught up in the current paradigm of the criminal legal system. And so we've also done a lot of thinking around MOUD provision and some of the changes that have been made in the context of COVID. And so, the embrace of telehealth services, thinking about real and important linkages to public health or treatment providers in the community, which clearly were not in place to the level of robustness that we needed beforehand. So when we get to the other side of this pandemic, thinking about the importance of public health, both in the context of substance use treatment and thinking about turning away from the criminal legal system and turning toward public health solutions. Thank you.
Thank you so much, Lauren. I'm so glad you were able to join us, and I am so appreciative of this presentation because for all of the griping about silos that harm reductionists do, I think there's a real blind spot when it comes to the fact of how quickly or how frequently many of our participants are also engaging in the criminal legal system, and the immense amount of overlap that there is for kind of multiple birds with one stone or kind of collaborative approaches in those spaces. So thank you.
Yeah.
Boston, you ready to go next?
I am. I'm just honored to be a part of this. It sounds like amazing work going on. Sex workers and jails is, you know, it's our life, and I'm glad to see all of that. So what I'm going to do is talk about a pilot project that we had. Bear with me here. Make sure I get everything working. A pilot project that we had last year, and I'll go ahead and start talking about it. I just want to bear with me. Okay. Ta-da, there we go. Pretty basic. We do this, the base pieces for a syringe service program. And in addition to the NASTAD CDC grant that we have, which has honestly changed the nature of what we do. It has been a godsend to be able to get folks and have that time to get folks into the treatment they want, and kind of navigate the barriers to getting that and have an advocate with them. We continue to do HCV and HIV testing. The thing that changed for us in COVID was that we started doing COVID testing. A close health department, not our current health department region, called and said, hey, I know you guys are experienced in testing. Can you come help us? And so we went down to start with the early point of care tests, which were junk, to be honest, but we started with that, and then moved into the swabs. And I'm going to talk a little bit about that program here. One of the things that we saw early on was the complications and the symptoms of COVID-19 would complicate overdoses, especially those that, you know, when you have individuals with respiratory symptoms, you already have low O2, you do a lot of dope, and things can happen. So we took it on as a priority, and that's why we dove in after we had that opportunity. What we did was partner with the health districts and Virginia Rural Healthcare Association. And they were the ones who helped get the project going for us. It was unfunded, which is why we're currently not doing it. It was a lot of resources to put together a testing team, but we'll walk you through it. So what we did, you know, we did like a lot of folks who were handing out face masks. It was pretty cool because what you see in the top right there are handmade masks. We had those donated to us from a mask maker group down in the New River Valley. Huge, and it was amazing, and they're great masks. So we were able to distribute those. We also had the HHS kind of Hanes tidy-whitey masks to hand out. We got out a whole lot of sanitizer. It's kind of cool because the hand sanitizer was locally sourced too at a distillery. So it was very much a homemade project. We were prioritizing folks who sell drugs, number one, are kind of low to mid-level folks because they move in so many social spaces. So we prioritized those folks. Then we prioritized folks living in hotels because we considered that congregate living. And folks, the rest of the system wasn't testing those people. We had help with shelters, we had help. They actually did a decent job, I think, here with jails as far as testing goes. And anyway, that was our project, was to take care of our community with the testing and to be able to put folks up in isolation if they tested positive. Because I imagine being on the street with the symptoms that I had, because I had COVID, is an incredibly miserable experience. So results. So this was in July. We, out of the 300 plus tested, we've only had 3 positives. I talked to, I think it was Dr. Chalk from Baltimore And he said some of the other programs up along the East Coast were seeing that low test rate as well, hypothesis being that they're not entering the vector points that most of us do in public spaces. So that was the work that was done. That's our team, and kind of want to talk a little bit about a survey. So we did a survey with the folks, and to be honest, I think it looks very much like the general population when I go to the store. You know, you've got the folks that are wearing masks, you got the folks that aren't, and it seems like a pretty even breakdown there. Folks did, or at least told us, that they started using more hand washing, more sterile, hand sanitizer and things like that. You know, I don't know. We did those three. We'd love funding to be able to put together another program. I think we did it too early. Obviously, Virginia cases this fall took a huge spike. So that's my presentation. I'd love to leave a lot of time for questions and answers for all of us.
Thank you so much. Yes, that's basically the segue I was leading into. Before I get started with any of the discussion questions I have, are there any responses or follow-ups or questions that the panelists have for each other?
I mean, I heard a lot of, they echoed a lot of the things we saw. We started 2019, I think, with 500 participants. As of December, we had 1,200. So we more than doubled over the course of 12 months as far as folks coming in, doing enrollments, engaging in our services. So that spike echoed what we see. Anyway, it just seems like great work that the other folks are doing.
So for both SPARC and Virginia Harm Reduction Coalition, how are you paying for this increase in demand on services?
SPARC has about 4 to 5 different funding streams, and 2 of our funders worked with us to help redistribute some funding. So like Jesse was describing, we had yoga classes and things like that before that we can no longer host. So we were able to take some of that funding and turn it into supply money. We also started a new funding year with our syringe service program funder through the state of Maryland in October. So that helped us with the demand increase in meeting that demand increase. And then additionally, one of our community partners put a lot of pressure on local and state governments to be like, you all aren't providing the same level of syringe services that you were before, so you need to give the syringes to us instead. And it worked. She was able to get a ton of syringes throughout the summer, and then she helped distribute it among different SSPs in the city of Baltimore. So it was a mix of working with the funding that we already had to make it more applicable to the services that we were providing, and then also one of our partners doing this advocacy on behalf of all of the Baltimore City syringe service programs, of which there are like, I don't actually want to name a number because I might be wrong, but less than 10 and more than 5, I think.
Like I mentioned during my slides, it wasn't funded. It was something we saw the community, but we want to take care of our community, and we saw that those folks were being neglected in the drive-through testing, right? Most of our folks don't have cars. Well, it's going to be difficult when they started that. So that was the initial piece. We did get some funding for the hotels from Virginia Rural Healthcare Association, because I literally called them and said, hey, help. My folks are vulnerable and they're not getting tested. And they stepped up to the plate and were amazing with that. They helped us kind of house the folks that did test positive or were assumed cases due to symptoms. We've been lucky. Over the past 12 months, we've probably had 10 different funding streams from, small things, small checks to larger ones from, I literally got a $5 donation. But anyway, we've got 10, I think about 10 grants and funding streams that we use. And any of that stuff that we had to expense came out of our indirect costs, right? And so it's like, we added it to our suite of services when we did the outreach and we had it in the office. The problem is, like I said, that we've added an additional step that's a lot of time, right? We've got to have 4 people to use, kind of get a sterile field, at least as close to that as we can on outreach or in the office. So it took up a whole lot of resources in addition to the SSP stuff we were doing when we were mobile or in the office. So, you know, if I had money to hire more folks, we'd do it. And I think it's needed now more than we were trying.
Not to put you on this, any of you on the spot for your retrospective, but it's been a year basically now that we've been talking about COVID-19 and the impact of the pandemic. For some of us, it seems like that conversation has been nonstop. What messages or lessons are we still missing from the populations that we all work with? And what would you like to emphasize for this audience?
Can you say the question one more time? We heard it, but we did not process it.
I'm there with you. Basically, what messages about COVID-19, the impact of the pandemic, are not getting through on behalf of the people that you all are working with? Like, what do we need to be considering more in our response, particularly since a bunch of you mentioned going into vaccine rollout?
Yeah, I think we both have different answers based on our expertise. I'm thinking about COVID vaccine like acceptance, and so that the demand is there when we do have supply. So that has just been a really big challenge and project that I'm working on ongoing.
On my end, it's more of the social stuff. So the drugs, well, I mean, it's social and medical. The drug supply is garbage, and has been for some time, but since COVID, it's like especially garbage. And so it's giving people really terrible wounds and also forcing people to interact with people that they might identify as dangerous and don't want to identify with otherwise, but then they need to because their supplier doesn't have what they're looking for. The other thing is just the housing instability is really, really bad right now and worse than it's ever been. And Baltimore is a city that's full of abandoned houses. And so was not pre-pandemic uncommon for people to live in abandoned houses, but it's, I would say, more common now. We've seen a lot of evictions just because evictions are not allowed doesn't mean that they're not happening. And especially with people who have housing situations that are less documented, or people who don't necessarily have whatever it is that they need to maintain that documentation, it becomes really hard to fight back, especially with the courts being closed and people don't want to go to court, so the whole thing. And we've seen people move into hotels, and then hotels have been shut down because so much drug use has happened there. So people are just being like shifted around constantly, which is, as we know, not good on the COVID spreading front.
Yeah, I mean, I'll just add that piece about hesitancy is really interesting. You know, when in carceral settings, sometimes with other vaccines, we've seen uptake rates as low as 10%. We think about flu or things like that. It's been wildly different in most places. There's been high levels of uptake and less hesitancy than I think folks might have predicted. And I think that's in some ways an indicator of like just how awful it's been to be incarcerated in the context of COVID. It's never good, but I think it's been so bad. People have been so isolated and locked down that we see, hesitancy is an issue, but it's not as much as we thought. The other thing is this very clear connection between community spaces and carceral spaces. I think, the general population sometimes think of prisons and jails as places apart that don't affect the rest of us. And I think COVID has really shown a light on the fact that what happens in prisons and jails affects people who are incarcerated and also the rest of society. And so we can't think about it that way anymore. And then the other thing I think is that often, like so much of the work that I do that's not in COVID times is trying to increase access to MOUD inside of jails and prisons, which is important. But I think we get stuck in relying on jails and prisons to provide that service. And I think we need to get away from that, that's another tension in this work, that we need to increase access, but we also need to think about how to get people out of carceral settings and provide access in the community. So, we're doing what we can now, but we can't rely on criminal legal systems as a solution to substance use. And so I think it's tricky because we need to do what we need to do now. But really, we shouldn't have to be thinking about this.
One of the things we need to get our folks out of prison. That's a huge thing with decriminalization and all of those measures, and that would help a whole lot. I think one of the things I'm kind of tired of hearing is getting a call from a reporter who says, tell me how COVID increased all of the overdose deaths in the country. And I mean, we had a stressful year last year, man. We had COVID, we had an election, we had uncertainty, we had people losing their jobs. So the cortisol levels were high already. But, when I look at the data, our first quarter in Virginia saw a ridiculous increase in emergency room visits for overdoses. And this was before the lockdown orders in Virginia. I don't know if maybe it was here and folks didn't know and it wasn't testing. And if so, I'm more than willing to say you're right. But I think COVID's kind of like Purdue Pharma. It's a good boogeyman to have, but what's going into this is a lot more complex than that.
I feel like we're just getting to the surface of something there, Lawson. If you want to keep going on that thought. I mean, I've certainly been hearing like everything that was shared about the drug supply, about housing instability, about networks changing.
Sure. I mean, like,
there's a lot going on.
Yeah, I mean, so I think one of the things you asked me early on was what is rural, I think kind of a talking point, what does rural homeless, being unhoused look like? And I don't think it's any different than the folks in Baltimore described. I mean, if you're in Henry County, Virginia, you're probably in an old abandoned farmhouse, right? In an old abandoned. It's just different because you got to walk a lot further or get somebody to let you ride in the back of their truck there. One of the things we have, and I think this is why it's good we're in Roanoke, is that the surrounding areas don't have the resources for folks who are unhoused. And so one of the things they do is buy folks a luggage, like some sort of luggage and a bus ticket and send folks up here. So a lot of it ends up here regardless of where it starts. And the drug supply has been crap. Thanks, guys in Baltimore. Y'all are sending out stuff that's no good. And we've seen those wound cares. I think early on, one of the biggest impacts we had in Southwest Virginia was the meth dried up. I couldn't put my finger on it. I couldn't find out what the source was. My guess is that it was the COVID restrictions of stuff getting into the country that made it, because shake and bake getting around as much anymore. Locally sourced stimulants aren't a thing. So we had a kind of a drought in meth, and we saw, and this is, I think, another factor. We saw folks move from meth to heroin because they were looking for a high, even though it wasn't their preferred high. They were opioid naive and artisanal meth. So anyway, folks that were naive to opioids were turning to them, and they didn't have the tolerance. They didn't have it. And so I think there was a huge spike in that happened as well.
I hear that. Does anybody want to respond or follow up with anything, or I will go to our next question? audience, please also feel free to put in any comments or questions into the chat box.
I mean, I guess I'll say this is like not a new thought, but I think it's worth calling out that like similar to what Lawson was saying is that the same communities that have been rocked by COVID-19 disparately are the same communities that, you know, have been most disproportionately affected by structural racism, by residential segregation, by, you know, lack of resources for public housing, for public transit infrastructure, you know, like none of this is a surprise to us. It's all very intentional. It's the same communities over and over and over and over. And so we, you know, we have carceral systems, we have broken drug laws, we have bad drug supply, we have, but really it's this structural overlay that it goes back to the very foundations of this country. So, you know, like that's the stuff that we have to fix. You know, like we need to get testing out, we need to get vaccines out, but like if we don't address structural racism in this country, then, you know, all this is going to exist the next time, you know? So, you know, we really have to think about like what, like it's all the same sources of everything. And we can't, you know, like I get called by reporters 1,000 times a day and they want to talk about like what's happening right now. And like, do I think there's hope for the criminal legal system and change after this? And I always say no, because we haven't addressed, like we haven't addressed the root causes of these problems. So, you know, we saw a lot of people maybe be let out in some places, very, very beginning of the pandemic. We're right back up to where we started because the system is still the system. We haven't changed that.
Second that, for sure. Following up somewhat on that message and some of the messages from earlier, how can harm reduction programs identify and act on participant needs and some of these emerging trends and issues and conversations in our communities, act on these developments in our roles as first responders, but without taking on more unfunded work? How can we best support broader partner-based action, and what is the role, what does our appropriate role look like moving forward? Or in an ideal world, what might that division of labor might look like?
It's a hard question to answer because I feel like people who are attracted to harm reduction type work are also people who are less inclined to say no and more likely to say maybe let me think about it and then we're going to figure out a way to do it. Even like Spark is geographically limited if you look at our service provision on paper, but people move around. Like they leave county lines, they move to different parts of the city. And so that's something that we've struggled with a lot with deliveries is like how to meet people where they are when where they are is not on our schedule.
Or outside the city.
Yeah, or outside the city. And so many times people have to relocate because of factors like outside of their own control. So your question is very hard to answer because normally we're like unfunded work. That's like for example, Spark 2 years ago, most of our funding was HIV prevention money. So we had to be very creative with like glass stems being, or Pyrex stems being like, I forget what we were categorizing them as, but Chore Boy was like a cleaning supply for Spark. It wasn't something we were distributing. It was just like, gotta keep the bathroom clean for HIV prevention. So it's, I don't know how to answer your question.
One thing that's evolved out of COVID is this like SSP collaborative that we kind of have made up. And it's Spark and a couple of the other SSP harm reduction centers in Baltimore. And maybe that's an area where we have worked. It's been a positive movement in the last 12 months of like sharing work and also sharing supplies. But you know, like if somebody moves outside of our district and moves into you know, another one of the harm reduction centers districts, then we can be like, oh, you know, pass them off to that person rather than like taking a special trip, you know, a half an hour away for them. So I think collaborating between different centers has been really helpful for us. Yeah,
I
and
appreciate that for sure.
I
Oh,
see
go ahead.
Kristen had a very good comment, advocating for supplies from the health department, collectively, you know, using our collective power to do that. That is very true.
So
I
Lily,
appreciate, oh, go ahead.
so the question is, how do we adapt to those? Is that that's the question? How do we adapt to emerging situations like COVID?
I guess in a broader sense, how do we balance this idea of being first responders during COVID and trying to keep things rolling and figuring out how to keep programs moving, with also recognizing that there are other programs and other people who might be able to fill some of those roles, if not better than we can, then with more resources or with more support.
You know, I feel often that we end up doing the work that nobody else wants to, especially in syringe programs, right? And I mean, and we have that role. We are, you know, I get in these community conversations, I get in these community meetings, and I was sitting there with Ariel yesterday, our drug user resource coordinator, and I was like, they have no idea what we see every day. They have no clue. The people with power, the people with the money have no idea the folks that walk through this door. And, you know, we need some recognition as folks who do good work. We are testing, right? We have experience with testing. We do a lot of HIV. We do a lot of Hep C. We're experienced with getting folks into care. Well, now we are, thanks NASTAD. But yeah, I mean, health departments need to call the harm reduction programs and say, hey, you can get to people we can't. We need your help, right? And here's some money to do it. And here's some funds for gas money, for the supplies you need. Here's the PPE that you need. Go bless the world.
There's something I started thinking and then saying to people pretty early on last year, which is I'm so split about this whole topic of COVID-19 and harm reductionists, because on the one hand, I have more faith in harm reductionists and drug users and sex workers to figure out how to live and survive in all of this chaos than just about anybody else. But I also know that those populations do nothing but live in chaos, and it might be really nice to take a break and to be able to rely on some other people for some help and support right now. So yeah, it's a bittersweet feeling to know that you all are out there doing such incredible work, but also facing such odds. I want to punt a little bit to Lauren and ask, for the SSPs and harm reduction programs and state health department staff who are listening in and thinking, what can we be doing to support incarcerated people and to address conditions that people are either living in or exiting during the pandemic? What can we be doing? What are some roles that we might be able to take on?
Yeah, it's a good question. I think one, you know, just really recognizing that the experience of incarceration is a trauma, and so can be and is detrimental to people's health broadly. You know, I think, like, I work in the field of public health and know lots of wonderful people doing wonderful things, but there has been this siloing of carceral health, and that's thought of as separate from the field of public health. And I think that's structural in many ways. You know, I think with their funding stream problems, right? Like, jails and prisons have their own line in a budget. So it's like capitalism, but it's their own line in its budget that, you know, so they take care of that, and public health has been separated from that. And so, you know, I think there's a structural reason why the separation happens, but I also think there's been some ways of marginalization in the field for, you know, people who are incarcerated. And so thinking about carceral health as important and integral to public health, and then also thinking about, you know, what do we do to ameliorate the harms of incarceration once people are in the community, both for themselves and their families and the communities in which there are high rates of incarceration. I think, you know, I touched on this before, thinking about movement away from investment in carceral systems, into public health systems, and thinking about all the ways in which incarceration impacts all these social determinants of health that also impact health. And so there's the direct connection, and then there's the connection of, like people no longer have access to stable housing in some settings, no longer have access to certain types of jobs. We're ruining social support, interpersonal relationships. All those things go to affect people's health. And so I think the acknowledgement that that is all real and very true is an easy step. And then I think the other thing is thinking about, like how do we make better connections between people who are leaving incarceration in the context of COVID and more broadly. But I think, Lawson and Katie and Jesse also talked about the need for housing, right? So safe places for people to be when they've been in these places where there's high risk and likelihood of exposure. So thinking about safe places to quarantine. And so, how do we get hotels for people or other spaces for people to be safe, the access to a test upon release, and then also once folks are back into the community, and also for people that they may be interacting with in their family. I think are really important. And then, we have thought a lot about overdose in the pandemic, and thinking about how there are all these MOUD programs who have kind of been put on hold. Like we've seen that there's less access to MOUD in jails and prisons, which is part of the reason why jails and prisons like this shows us can't be the response. But making sure that people have access to MOUD as soon as they get out, especially in states where we're seeing mass release. In the state of North Carolina, in the next 6 months, there are going to be something like 3,900 people who are released and this is because of litigation in the state relevant to COVID. And so, when we have that massive number of people who are released, public health has to be, they have to pull a seat up to the table to make sure that people have what they need in the community.
I have a question for Lauren, because I am fascinated by this work. So when you have this research, how do we put it into policy so that those things have changed?
You're like, nice ideas, lady. What do we need?
How do we get, no, they're not just, they're amazing. How do we get it out there and change the stuff?
Yeah, I mean, part of what we're trying to do is aggregate data and stories from people who have been incarcerated in this time to advocate for policy change. And so I mentioned that we've been working with Senator Elizabeth Warren on 2 pieces of legislation using our data to illuminate just how bad it's been, and how jails and prisons have been the epicenter, and there has not been a response that is adequate. And so I think using that data in practice, making sure the data are available in real time, like a lot of times any health conditions data, you have to wait like 5 years for the Bureau of Justice Statistics to release it. It's meaningless. So we're thinking about how do we get data in real time? How do we continue to open this door relevant to data transparency? Like these COVID dashboards are going to go away, but we're really pushing for them not to, and pushing for even more. Like we need to know what's happening behind the bars, what the quality of healthcare that people have the constitutional right to is like behind the bars. And then we need to hold jails and prisons and public health entities accountable for, like what's going wrong.
I think Lauren mentioned something about resources in the community before incarceration or after. I think it was Tracy Helton who said one day, the story "prison saved my life" is not the story. The story is you didn't have the resources that you needed before you went to jail. The community needs to develop those. So anyway, that's something I hear a lot of, and I don't think it demonstrates or sheds a light on what the individual is talking about means. I think it's a systemic piece and not an individual piece.
Also, just based, because you mentioned the North Carolina lawsuit, Lauren, a big week for our North Carolina colleagues with hepatitis treatment for incarcerated people. Very good news and exciting traction there. There is a question in the chat box pertaining to our discussion earlier about drug supply. If there is such a bad drug supply, how do we account for the increase in fentanyl use and becoming the preferred drug of choice? So can any of you talk about fentanyl use or fentanyl seeking among participants in your programs?
So it's cheap and it was easy to get here. And it probably is today just because it's so potent and you can ship small amounts of it. So, I mean, and that's what folks at the bottom rely on when they make the cut, right? It's still strong enough to give them the reaction. And it's the adulterants that come to there. So in Baltimore, it might start off pretty decent. I know they're talking about adulterants up there, but by the time it makes it down 81 into Southwest Virginia, it's, you know, it goes from a pink to a gray because folks have put so much benefiber in it.
A lot of the drug supply issues that we were seeing were happening like on the corner level. So it's people who are working the street trying to make more money. So they're taking what they have and they're cutting it. And we saw cuts in the beginning that included meat tenderizer, which like eats at people's skin and flesh, and you can like lose limbs very quickly because of it, like within days. And then we also were seeing a lot of cuts with sleeping pills and benzos, and just a lot of people, which is common, but it's a lot of, in our neighborhood, a lot of kids playing pharmacist because they need more money. So I can definitely imagine that it's pretty crappy by the time it leaves the city. But it's more like individual level people trying to make biggest bang for their buck. And like you're saying, fentanyl is the cheapest and readily available. And there's a lot of competition in the market around here. So in any given day, there's multiple people giving out samples and testers and things like that. So you have to have something that has something like benzo where you might fall asleep, but you don't realize that it's not a dope high right away. Things like that. People have gotten really creative, we'll say.
And you all in Baltimore have a follow-up question in the chat about whether you've seen wound botulism on the East Coast. On the West Coast. Oh, there has been a lot of wound botulism on the West Coast, excuse me. So if you could go back maybe to what you were saying earlier about how the wound care that you're seeing has changed, going to more of a triaging than prevention dynamic.
I am not sure what the question is. Sorry.
I will also add to the part that you added, just to clarify, one of the reasons we're seeing more wounds is one, the drug supply, but two, because Jesse's offering services outside of the building, not inside the building. So before, if your leg was very inflamed because you had a wound, you had to you weren't traverse the sidewalk to get there.
Yeah.
Now we're like, who's in this abando? What's your leg look like?
Yeah.
So that's a big part of why we're seeing more wounds.
Got it. Thank you, Hannah. And thank you to both. That certainly makes sense.
You're muted, Lily.
Happens to everybody. We've got 5 minutes left. Are there any other questions in the audience that we want to be sure to get to with our lovely panelists here?
I have a question. So for Katie and Jesse, but also Lawson and Lauren, if you want to weigh in. So I'm just thinking about kind of the shift in service delivery and kind of relationships that's happened during the pandemic, particularly with Spark, when you talked about like going to all delivery based, more consistent staffing model. And full disclosure, I'm not just asking this because I was one of the casual staff people who would go out and do outreach with Spark, which was wonderful before the pandemic. But so I'm wondering, like, what are you thinking about what it looks like as vaccination rolls out and we start to get to more of a, I don't know, post-COVID or less COVID impacted world? like what lessons will you take from the ways you've changed service delivery and like keep in place? And I'm also interested in like, how do we get just like more low barrier medical care to people, which is obviously needed based on your experience?
Yeah, that's a really good question. I think that we will keep doing the delivery service and also keep doing more street medicine. Prior to COVID, we didn't really do any street medicine. I don't know if we ever did street medicine actually.
We handed out wound care kits where people could
do their
yeah,
stuff, but I never
but
went out.
not Jesse.
Yeah. So I think that that is necessary, whether it's fixed site outside or like home health visits basically for wound care. And then also just like rogue street medicine, where I have a backpack and we're walking around. I think that we'll continue doing what we're doing now because our numbers have increased like times, 4.
So many.
But, hopefully we'll be able to open the center again, where we can provide more care that requires that sort of stabilization. Or that might benefit from that sort of stable, place. I think that that's where Hep C and like HIV care can hopefully come back in the picture, and PrEP care. Also, the people who walk into our building are just have a different level of stabilization in their life to even get there. So the kind of care that they need is just different than what people need on the street. So yeah, I guess we'll continue doing what we're doing, but we'll just double ourselves and have the brick and mortar.
We also, I feel like I would be remiss to not give a shout out to the outreach team that worked at night, because that's how we met everybody to begin with. And we've been distributing that Google Voice number prior to COVID, like prior to closing. So people had the number, they just never used it. And then once we closed, people were like, how do I get back in touch with you? And then going through their stuff and finding little cards with their numbers on them, or hand sanitizers with their number on them, or whatever, and then reaching out. So if we hadn't been like reaching out over the years coming up to COVID, we wouldn't have been able to reconnect with people in the 2 weeks like we were able to. And then the other piece that was huge for us that I forgot to mention was secondary distribution. We had a few people who were like, you are northern this part of this neighborhood, you are southern this part of this neighborhood, until we get more addresses back in this block, like you're going to take 5 bags and you're going to take like these whatever supplies and you're going to redistribute, like, because you're going to still be seeing people, like especially houses that were a little bit more of like tract house style, or like the one house on the block that has running water or whatever it is. Those folks in our community were instrumental to us being able to get the supplies out that we were really trying to get out, especially in those beginning months, because as we know, like nobody knows drug user health better than a drug user, better than somebody who's already in the community, like already there. So they're like the real underground MVP of that chart that looks pretty. It was a lot of their work too. So, and Kristen's right, we never got out of the van before because we were going around at night. And so that is another aspect, like another reason to keep it during the daytime. It is a little bit safer to some extent. We still have shootings that happen during shifts and things like that, but it feels a little bit safer when you can see more of the area around you and know when to leave faster. So, yeah.
I definitely will, affirm that many programs have highlighted how instrumental and critical and vital and all over the rest secondary distribution and community-based partners have been during the whole pandemic, and working on ways to start getting looking at ways to start making sure those folks are getting paid as well. So put that on your priorities list, folks who are controlling budgets. It is 4:30 in North Carolina at least, and we are at time for today. We will plan, if I can act quickly, I'll put contact information in the chat box. Panelists, feel free to do so on your own. We'll follow up about sharing slides and all the rest, but just a huge thank you to all of you for spending time this afternoon and doing our best to make this feel like the harm reduction conference setting that we're all missing. So thanks so much. Really glad to see your faces. Yes, and we will see you tomorrow at 12 noon, starting with our policy and legal landscapes in the South. I think that says back in this Zoom space. Thanks, everybody.
This was great. Thanks, guys.
Thank you, panelists.
Thanks, everyone.